Hello, everyone, and Happy New Year to our audience. We have a show for you today. I'm so excited to have on the show two guests. And our conversation kind of came from a LinkedIn post, and we'll get to that in just a minute. But I want to tell you a little bit about them first. In healthcare, change rarely happens by accident. It takes time, persistence, and people who are willing to show up a long time before the win is guaranteed. In New York State, that work recently just paid off with new legislation allowing physical therapist assistants to practice under general supervision, expanding access and care, reinforcing the strength of the PT-PTA relationship. But what does that actually mean for clinics, rural communities, and for the future of our profession? Today, we are joined by two clinicians who don't just talk about advocacy, they live it. Practice owners, community leaders, and longtime believers in the PT-PTA team model. We have with us Megan O'Brien and Jeremy Biddle. Welcome to the show.
Hello.
Thank you so much. Hello.
Thanks for having us.
Yes. Yeah. Thanks for coming on. So I'm going to pop up here on the screen real quick. This is what I saw on Jeremy's LinkedIn. So this is the new win from New York State. Super exciting. We were trying to problem solve before we hopped on and hit record as to what other states don't have general supervision right now. We weren't really able to kind of come up with a full and complete answer for that, but we think that it might be somewhere around 49-ish states or something like that, based on a quick search that we did before we hopped onto the show. But before we dive into the questions, I want to give you two a little bit of time to kind of explain where you're from and tell us about your practice. Whoever wants to go first.
I can go first.
Go ahead.
Okay.
So we are from rural Western New York. If you split the difference between Rochester and Buffalo and basically went to the Pennsylvania border, we're right along that area. We own a outpatient private practice, and within the borders of that outpatient private practice, we also have a lot of contract PT and PTA work that we also provide to the community.
Yeah, and we'll talk about some of the challenges later. But I would say that in the last 3 years, we've streamlined our outpatient business into a more focused model, going from 3 clinics to 1, while we've expanded our external offerings and done more with contract work, which has been easier to manage in some ways, but also certainly improved in terms of payment. But we can talk about that at a later time. But the business model continues to evolve.
Yes, and I feel like I should also kind of just pre-warn the audience. You could probably tell from my voice, I have been struggling with this cold, whatever it has attacked me in the last week. So I will try to do my best to not cough or to interrupt our guest or to whatever. I hope that my voice comes through fairly clean. But anyways, I just kind of wanted to say that up front. I realize I don't sound like the normal Katie that's typically on here, but I'm so excited to talk to you two about this. And, what's always interesting to me is, I'll reach out to somebody. And so I literally just reposted Jeremy's post and said, hey, do you want to come on and talk to me about this? I mean, this is a really important thing. So obviously this podcast is just for PTAs. It's by me, I host it. I am a physical therapist assistant. All of the work that I do is trying to elevate the PTA and to strengthen the PT-PTA relationship. So having you two on, I think, is just super key to us really kind of solidifying that relationship and seeing how we have PTs that are fighting for us every day as well, to make sure that our patients can get the access that they need. And I think that we can address that through some of the things that you're talking about today with rural health and the contracts that you guys are doing. So let's just jump right in. We're going to start with the big win. So New York State's allowing PTAs to have general supervision. This is kind of like a big deal. And so from your perspective, what I would like to know, what makes this legislation historically important? This didn't happen overnight. Right?
Right. So I would start by saying APTA New York has been fighting for this change forever. And there are key players across the state, one of which is in Rochester, who was our professor in college, Marcia Miller Spoto, who is the chairperson of the Public Policy Committee. And she has fought for legislation for many years on many different topics, but this is one of our huge wins, which is great. And to us, it really allows for greater flexibility. And so, from the PT's perspective and from the scheduling person's perspective, Megan creates all of our schedules on the outpatient side and also kind of organizes things with our contracts. So I'll let her talk about it in a minute. But essentially, every time there was someone calling in sick or anytime someone went on vacation, it created a huge issue where instead of canceling one schedule, you'd have to cancel 2 schedules because there was no supervision on that particular day. When looking at hiring a PTA, you always had to think about, what PT was working, what their hours were. Would the PTA that you were interviewing be okay with working that person's hours? Because obviously when you hire a new employee, you don't necessarily want to change an existing employee's schedule to fit into that supervision model. So those were some of the difficulties that kind of stand out right off the bat that will be alleviated with this. In terms of the PTA team, which you mentioned, we were strong believers for a very long time in collaboration and looking at the strengths of the PTA in terms of their education, training, licensure, all those things. And while it is a very collaborative relationship, I think that our PTs really have a appreciation for the knowledge of the PTA and what they're able to do within their scope of practice. So I think that lastly, the other thing it does is elevate the PTA's job value or their marketability.
Mm-hmm.
And so I think that it makes them more marketable. So it elevates their status. That was the word I was seeking a minute ago. But it elevates their status to the point where if a PTA and a PT apply for the same position, it makes them more parallel in terms of, the employer's eyes and what they have to do.
Based on flexibility.
Right, based on flexibility.
Yeah.
So prior to this legislation, it would be like, if a PTA applied, well, how are we going to fit this into our supervision model?
Right.
Can we put them in an external contract? Do we have to position them in an outpatient clinic where we might not even have a full-time job? And so it really provides a lot of flexibility and elevates the status and marketability of the PTA. And I'll let Megan chime in on some of those topics that I kind of
I would say that, even when you discuss, it's never been a real limiting factor for us because we always do see the value in that. And we have a great team and we have great physical therapists that are flexible and also know that we're flexible with them. So, our employees can work a full-time job in 3 days a week. They can work in 4 days a week. They can work in 5. Like, we're pretty open to what works for people's work-life balance, their life in general. But have always had the caveat of, but if you're the PTA, then we have to figure out how to make that happen. I think we are unique in that flexibility with everyone, and a lot of places aren't. So especially if you're looking at a practice that isn't ours, there's probably a lot more likelihood that could be a barrier, to, well, I'm not interested in managing a PTA schedule when someone calls in. I'm not interested in managing a PTA schedule over the holidays. I'm not, those little things that, like, we've always done it. We've always seen value in a PTA. From the start, the facility we both worked at prior to opening and having our own practice, we always had a PTA team. So it was kind of a non-negotiable for us, and we've always been open to it. But for people that were less open to that and saw some of the things that may be more difficult to manage and aren't interested in adding another thing to manage when you're running an outpatient clinic, that's not an excuse. There's no reason to say that anymore, because now they can work and they can be in a contract, and they can, if the PT calls in sick or the PT oversleeps or the PT, all the million things that happen with all the moving parts that we have, then it's not a problem. And, our PTAs are in our clinic are some of our longest standing employees and super valuable and great at what they do. So it's so frustrating and insane sometimes when you look at something and you're like, oh, well, so they should not be able to work this day because so-and-so called in. Like, that doesn't even make any sense because they can see all these patients. They don't need someone standing there, So for us, we've been in practice for 20 years plus, each of us. And this has been something that's been discussed for the majority of that timeline in New York State. So, we're old and it's really been a long-standing, like the PTA supervision, PTA building. So when it actually shows up and you see it, you're like, oh my gosh, it happened. It actually happened. It wasn't something that, in the amount of work that goes into that behind the scenes from people like Jeremy mentioned is just crazy, over the course of years, and how important that passion is to push it forward and make it happen.
I mean, just to give you some perspective on how slow New York is, 2 years ago, PTAs were not able to get paid under our workers' compensation fee schedule for workers' comp visits. Now they can. So this is just another positive step in the right direction to really allow PTAs the professional freedom and ability to collaborate that they deserve based on their training and their expertise.
And I also think we were talking before we started this, but in this world, we're all used to seeing extenders for like primary care, right? So you sick, you need a doctor's appointment. Do you see a doctor, or do you see a physician's assistant or a nurse practitioner?
I was just talking about this with somebody the other day.
Yeah. And the beauty of that, especially for us in rural healthcare, where it's difficult to recruit a PT, it's difficult to recruit a PTA. It's very difficult to recruit a physician to, for our local healthcare networks, is that when you call and are sick and they're like, yeah, we can get you in, they're getting you in because they have extenders. Like that's who's saving the day. And I know, I've spent years where, of course, there's a supervising physician, but I'm seeing an extender for all of my care. My child sees an extender for all of their care. And like, I don't think twice about it. They spend a lot of time with you. They're able to listen. Their paperwork and like supervision components that the physician has are not burdensome to them in the same way. And so sometimes you're like, I got better care from that. I think the same thing happens in parallels in PT and PTA and then that relationship. And so the fact that it took so long is kind of insane when you look at the comparative medical model that does the exact same thing.
There's so many things that I could say based on the few minutes that you two have both been talking. I think that, I think it was Jeremy that mentioned elevating the PTA status. I think that having a win like this is going to open that up for PTAs to feel that they have the permission, that they have the motivation to maybe seek out more of those certifications or specialties or trainings, because they can feel themselves being elevated based on this law alone. Now, I come from Ohio. We have had general supervision in the state of Ohio, other than private practice, for many years, up until Medicare changed their rule last year. So it was always very strange to me. I grew up in the outpatient world, grew up as in as a baby PTA, growing up in the outpatient world, but I was in a hospital-based setting. So to me, I didn't really ever think about it from the private practice perspective, is all of those barriers that you just mentioned, calling off and having to cancel a whole caseload of patients. That's just crazy, to think about that, because in the state of Ohio, it wasn't something I ever dealt with, not in a hospital-based setting anyways. But it was always so interesting to me. I would explain this. I teach, and so I'm teaching PTA students up until last year, that the PTAs in outpatient practice have general supervision. Across the street, there could be a private practice. They needed that direct supervision based on Medicare rules. Yep. And to see the confusion on my student's face was, I'm like, I know it doesn't make sense. I understand that. And I can see what you're telling me by the look on your face, but it was the role at the time. Just absolutely insane. So I love that you guys brought up all of these things about, the barriers that it had caused and created, and that it's elevating that PTA status, that it's elevating the PT-PTA relationship. And then the advocacy that's been done, like you said, this didn't happen quickly. This is something that New York has been wanting to have happen for a long time. And I don't know, maybe what was it, the push from the Medicare perspective, that whenever that freed up, do you think then that gave New York like the freedom to feel like, okay, now we can do it? Or was it coming anyways? Like, do you feel like it was already in the works?
I think that the government, whether it's federal or New York, is starting to see the squeeze that the healthcare system has on providers. And
Mm-hmm.
in some cases where they can pluck at low-hanging fruit, they're allowing some of the burdensome regulation to be relieved so that healthcare providers and patients have better access to each other. And I think this was part of what would be called reducing burdensome legislation and burdensome regulation in our healthcare environment. And so I think it was part of that essential focus point to try to increase some of the bottlenecking that's going on because of the lack of providers and all the difficulties we have in the healthcare system.
I will tell you that, over the course of years, you get information from your local state APTA. For us, it's NYAPTA, but whatever state it's in. Here's this letter. Send this letter to this representative that's your local. We've always done things like that. We've always filled in and added and supplemented and really felt like that was something like they basically write the whole letter for you. Of course I can send this. It's insane. Not
Easy
to.
peasy.
Mm-hmm.
But being able to back that with the Medicare thing, adding in that, like that gives more bulk to your letter, right? That's like, how do you argue that? And every other state, we've been saying that about other states for years, but now this national payer is saying, what are you doing? So, being able to send information to your representatives that they can look at it and have the same perspective of what your PTA students had is probably, more valuable of, well, why would we do this when other states aren't doing this? And now Medicare's not doing it. It doesn't even make any sense. So,
yeah.
One thing you mentioned was in regard to elevating the PTA status. So I think even within our own profession, there is some friction at times and in certain environments between PTs and PTAs. And I think that sometimes PTAs disengage because they feel like there's a barrier there, which we don't want there to be a barrier. But I think that we understand PTAs perceive there is a barrier and perception is reality, right? So this has also been recognized at the APTA level. And there's a lack of membership from PTAs, PTA or APTA New York. And, I think nationally, APTA is looking at ways to re-engage PTAs. And I know there is a sort of a certification track program that they're looking at implementing to allow PTAs some of that professional development opportunity that maybe wasn't there. But I also think that this type of legislation helps to relieve some of that friction, but also helps PTAs to know that they're appreciated and that they are free to do some things that are well within their scope and well within their training, and they can really work on being the best professional they can be.
So you hit the nail on the head when you said perceived barriers. I say this a lot on the show too. I kind of feel like when I started the show, I don't know that Am I muted?
Can't hear you.
You can't hear me? So one of the things that you had mentioned was the PTAs perceive something, and perception is reality, right? And this is something that I talk about a lot on this show, is that when PTAs bring up barriers to me, I often want to ask them the question, is that what your perception is? Or is there really truly a barrier? Or have you not asked the right questions? Like, did you not go to the right person and figure out what's going on here? Because sometimes I think that it is truly a perception thing, and that we hear assistant and we kind of run with that, well, assistant makes me less than or whatever that might be. So I'm excited to hear about these tracks. Is this a New York thing that they're coming up with tracks, or it's an APTA?
This is APTA National. And so I double as the vice president of the Academy of Leadership and Innovation for.
Oh yeah. I've had a couple people on from LAMP.
Yes.
Yeah.
So I get some information sometimes earlier than other people, but they are developing these tracks. But I think the key point is that APTA for years has known there's an issue, and they know there's an issue because there's disengagement at that level, right? And so if there's disengagement, you have to get to the reason why are they disengaged? How can we engage them? And I think one of the things they were hearing was professional advancement. And so I think even in our own clinic, we're constantly seeking ways to try to elevate the professional status, the practice status of our PTAs. And I'm McKenzie certified. An example is, well, a PTA can take McKenzie Part A and McKenzie Part B, but they can't take Part C or Part D or Part E. And E doesn't really exist anymore, but that's a different story for a different day. Right. But, why can't a PTA take advanced problem solving, that sort? So there's different things that these initiatives, I think, will allow PTAs to do things that they weren't doing and focus on things that they haven't been able to focus on in the past, and allow themselves professional development to a degree where they're able to interact with PTs on a state or national level more, which hopefully engages them and brings them back into that centerpiece.
Yeah, I love that. I always think of the example for me, in the state of Ohio, PTAs can't do dry needling. There's no reason for me to do dry needling as a PTA in the state of Ohio. But if I'm going to work in a clinic that does it, I better understand it. I don't have to do it to understand it. I can have conversations. I can do a little bit of education on the side, but patients are going to ask me questions. So I better be prepared to answer, at least some of those, or to be able to direct them back to the PT who did the treatment with them. But just because I understand it doesn't mean that I can do it, and vice versa. You know what I mean? So I don't see that there should be any perceived barriers from that perspective of you can gain the knowledge. We might not be able to do every single skill, but I should still have a very foundational understanding of what the physical therapist is doing that I'm working with. I should have that basic foundation.
If you're on the healthcare team and you have that knowledge, as the PTA, you could say, do you think patient A would benefit from treatment X? Because I went to this training and this is part of my knowledge and I think that they would. And that's what collaboration's about. So the PTA can't do it, but you can certainly suggest it, understand it, and try to elevate the status of your patient by knowing those things.
Which is no different than even if you look at us from the perspective of our physician relationships, right? So you see a patient and just the other day I called on a patient. I have a vestibular certification. And I called on a patient that, primary care is trying to manage, but the real story is their primary care. They know a lot about everything. I know a lot about this one thing. So I said, I can't order imaging. This person needs imaging. So I call and say, hey, I evaluated such and such. We did this, and this. Well, I have to have an understanding of the imaging. I have to have an understanding of the physician's viewpoints. I have to have an understanding of that whole medical management that, treating this person is outside of my scope. They don't need PT, but I'm going to have this conversation that I have to have an understanding of everything to be able to get my point across and to make any gains for the patient. So, and, we have direct access in New York State. It's somewhat limited compared to other states, but I don't have to have a physician tell me what I can and can't do, but I need to understand their perspective and be able to communicate with them in a way that makes a change for the patient. So,
yeah, I love the comparison.
And in New York, we can't dry needle at all.
Yeah.
In New York, we can't dry needle at all, although we would love to.
Oh, okay. That's interesting. I didn't realize that. Yeah. It's so interesting to think about all of the different nuances in state laws. So there is a Facebook group, love it or not. It kind of depends on how people like Facebook and social media and things like that. But there's a Facebook group called PTA Professionals. And lots of really interesting information comes through there. You can kind of see and feel like the stress points in PTs, PTAs, that kind of thing. But it's always interesting to me when people pop in like, hey, can I do X, Y, and Z? And me as an educator, I'm like, you got to go back to your state practice act and find out, like in the state of Ohio, you're not going to find the word joint mobilization in our practice act. It's silent. It's not in there. So that opens up a whole nother other can of, worms whenever it comes to the conversations about joint mobilizations with PTs and PTAs in the state of Ohio. But you can like type in the search bar and try to find joint mobilizations. It's not in there. So, whenever I see people post those kind of things, I'm always like, man, you got to go back to your practice act and really kind of dive in and talk to somebody from your board. There's got to be somebody from your licensure board that can answer some questions for you. And that's what they're there for.
Right.
They serve.
And just one last point in regard to, is the friction perceived or real? We've been in environments where it's real. So we've seen it where a PTA or a PT or a certain system doesn't appreciate the value of the PTA and doesn't respect them practicing at the top of their license. And so we try to alleviate that. We try not to have that be the case, but we certainly have seen places where it happens. And so we can understand why in some cases that perception actually is reality. But like anything else, if that's your environment, get out, right? So,
yeah. So I guess what I would like to kind of drop in right here, right now, is that if there's any students listening, these are the kind of things, these are the kind of conversations that you want to have with someone before you're getting hired. Whenever you're doing the interview process, how are you going to support me as a PT or a PTA in my professional development? Because if you want your clinicians to win, you're going to infuse every chance you get professional development or other kind of education to kind of make your team stronger. So those are the kind of things that I always tell students. I'm like, you need to ask these things whenever you're taking your first job. What does that look like for me? How do you support the clinicians, the PTs and PTAs, so that they can be better for your patients, right?
Yep, absolutely.
Yeah. Another interesting thing, and honestly, this conversation has went in so many different directions. I'm not even on like the pattern that I had initially, kind of outlined in my head, but you mentioned the extenders. And I was just having this conversation with somebody the other day. When you go to the dentist, how long do you see the dentist?
Right.
I think I see the dentist for about 45 seconds, right? But I see a lot of other great providers that take very good care of my teeth and my dental health and all of those things, right? So we are building in these ways to support our healthcare system. Now, I know dentistry has a lot of other things that maybe we can learn from, or not. I'm not so sure, but nurse practitioner, I don't remember the last time I've seen a physician. I have seen a nurse practitioner for years. So, it just kind of, it can work. And I have full trust in these extenders, right? I've always received good care. So I think it's a very interesting parallel that we got going on there too. So, all right. So next question, reality check. I would really like it if you guys can kind of give us what this outpatient physical therapy looks like right now. So here you are in 2026, you're private practice clinic owners. What is outpatient PT really like right now? And how does this regulation help or change that reality? So you can dive into all kinds of topics, staffing, reimbursement, burnout, sustainability. So like, where are we? What's going on right now in private practice?
All of the above.
So yeah, I mean, I think every place would tell you. So we struggle in New York State. So lowest paid state, lowest paid region for outpatient PT is where we live. Cost of living is also very low, to clear transparency. I don't even know why, but the other day I like Alexa and said, hey, Alexa, why would anyone live in? And I said the name of my town, which is Tiny, because I was like, they know everything. What would they say? And they're like, a community feel, low cost of living, outdoor access, nature, like whatever. So, okay. I mean, to me, it's like you joke because I'm born and raised here. No one would live here. Why would you live here? But we do have a lower cost of living. We do have these wonderful things, but a lot of that is really difficult for outpatient practice. Mm-hmm. A lot of other areas that would be rural or have some of the things or struggles we have, you can also get paid a lot of money. That is not Western New York. So, you mentioned staffing, you mentioned retention, you mentioned burnout, like all of those things. We struggle with all of those issues every single day. They are probably the top. Every word you said, we talk about each one of those things at least once a day. Recruitment is super difficult because we are so rural, and it turns out that when you're established somewhere, you're not going to pick up and move your whole family, and when you're not established somewhere, you don't necessarily want to live in a place with, the most excitement is that we have a Wegmans, which is a great grocery store. 2 thumbs up. But we certainly struggle with all of these things, and we do tend to think, okay, like that's where we live. But then we are also involved nationally. So we've gone to Graham sessions for the private practice section. We just came back from PPS in Orlando for private practice, and every private practice is saying the same thing. And we giggle to ourselves because it's like, well, we make $62 a visit. You make $112. You think you got it bad, because you're always comparing, but they do, we're all struggling. So I would say generally across the board, there is a struggle in outpatient private practice for sure. For us, each and every one of those things you mentioned are difficult. It's hard to retain. Because of burnout, we just learned the stat. Jeremy's better at remembering the numbers. I am not good at numbers. So I'll let him speak to it, but about like what happened in COVID. So
11% of PTs and PTAs left the profession in 2021, I believe. Mm-hmm. And we currently have a 10% deficit in hiring. So the people that left the profession for something totally entirely are the deficit we have. And so I would just kind of pick up where Megan left off and say, we've tried to address the things that we can. Number one, burnout. We used to run the typical 30-minute follow-up, 60-minute evaluation schedule, where the 30-minute follow-up, they might be in the clinic for 60 to 90 minutes and you're billing concurrently, doing all the things. But that schedule led to burnout because of the overlap between patients. And so we've moved to a 40-minute scheduling model. That's been great for retention and to reduce burnout.
And recruitment.
But it also obviously impacts reimbursement because you're having less patients per day. So even that came with its own challenge. But our biggest challenge right now, like Megan said, I would say is recruitment, and some of it's a factor of reimbursement. So this whole wheel is that every piece of the puzzle off the next. And so if you're getting $61 a visit, that's all you have to pay your people. And so we, if they make 11 miles from where I live is the Pennsylvania border, they might make $92 a visit on average, 11 miles away, where I'm making 61 or 62. And so if I'm making 30% more, then I can pay my clinicians all or a portion of that to help recruit and retain them. We don't have that. And so it's very challenging. And so I would say from a business model perspective, when you go to conferences like private practice section, everyone's looking at doing things differently. Mm-hmm. And so whether it's a cash model or you're adding, different services outside of the insurance model, or in addition, like for us, we do contract-based work with schools and local businesses and ARC facilities. That's been a huge help to try to offset the difficulties of the brick and mortar outpatient clinic. So it's very challenging, and I would say it's probably the most challenging it's been right now. Mm-hmm. And I would hope that at some point we feel like we've hit the pinnacle of the challenge and that maybe things get a little bit easier at some point, but I guess we'll see.
Sounds like you guys are doing all the right things, though. You're putting yourself in the rooms where the conversations are happening, and you're getting yourself into proximity with other private practice owners and really just kind of brainstorming to kind of think outside the box, because we keep relying on an old system that's not going to sustain and not going to do us any favors long term, right? So we got to kind of find a different way around all of these things. Tell me a little bit more about these contracts. So when you say contracts, like, can you give our audience a little bit of a breakdown of what exactly this is that you're contracting to do, and who are you sending into these contract settings?
Okay. Yeah. So we'll give you 3 examples. One is a school-based model where we send a clinician into the school, and all of the students that we see typically would have an IEP. And so they have some developmental disability, where we're working with those students to help bring their gross motor skills up to par. And in order to qualify to have an IEP, they would have to have some physical issue that caused them to be less interactive with their school environment to the point where it was a detriment to their educational process. So like that's one example. And so basically to achieve a model like that, you would speak with the CSE, principal, superintendent, come to terms on a contract where, you pay us X dollars per hour. We'll see your students that have these needs. And it's basically just a fee for service contract model. So that's one model.
One thing about that model is, and the reason why it really works for us is because we do live rurally. Our school districts are small.
I was just going to say, you might have a small school district, huh?
Yeah. And so if you have a small school district, you can't afford or have nowhere near the work required of having a full-time PT. So this allows them to have all the access to care that they need. So the students are being serviced. In some of the school contracts we've been in prior, like there's been no PT in that school for a year or 2 years or whatever it may be, but it's 3 or 4 kids. We do have some bigger contracts where it's 3 full days a week, but even 3 full days is not 5 full days. So we can work all of that together and put in a clinician who is interested in doing that and happy to be in that position and allow children in a 30-mile, 40-mile, 50-mile radius to get the services that they need. Whereas a school district can't afford to have a PT full time to see 5 kids twice a week. It just literally doesn't make any sense.
So the second model is an occupational medicine model where even though we're rural, we actually have the #1 rail car maker in the world here. And so we have a contract with them where we provide ergonomic assessments, and we also might go in to try to prevent injury with them, again, on a contract basis. And basically in that contract, you'd be talking to their health and safety team to establish, #1, your value and what you can bring to the company, and then, sell them on the service. And hopefully it's reduced workers' compensation injuries, reduced workplace hazards, improved efficiency in terms of ergonomics. So that would be kind of that model. And then the third model has been actually one of our best recently in the last couple of years, where we're doing work with ARCs and we're seeing adults with developmental disabilities. And this is a population who is extremely underserved. It's very difficult for them to find providers. And it's really a niche that we've fallen into that we really enjoy. It really gives our clinicians great satisfaction, and it gives the individuals that we see great satisfaction and a great service that they really need. So those have been really helpful to try to offset some of the difficulties that we've been having in the outpatient environment.
And if you look at, who's providing these services, because you kind of mentioned that when we started, is the answer is both PT and PTAs. So more specifically in New York State, in the school, we have utilized a PTA in the school, but because of the supervision need, it has been more difficult, right? So then they have to have schedules, and they're coming from different directions. And are they carpooling or are they not carpooling? And does that work?
Yeah.
Well, this person was at a school here and this person was at this clinic, and how do we make those ends meet? So I can see that becoming easier, which would be great. And then also when the work with the ARC, we very consistently have a PTA because the restriction or the regulations is much easier in that setting. So we have one of our PTAs who works with us, and Jeremy and I are the providers in those contracts as far as PT goes. So we have a PTA that works closely with us, and like last week we saw all the people at one of the ARCs, and next week she'll be seeing them. So we won't be in the building. We don't have to be in the building because that type of care was already outside of the loop of having to have direct supervision. So that's kind of been like the taste of it for us that we've had for years, where we're like, well, this is great. Why can't it all be like this? Because, she's communicating with us. I don't need to be in the building. I mean, she's every day when she's done, sends a big email and, outlines information. If she has a question, she texts us, she calls us. I see someone and say, okay, next week, I want you to give them this home exercise program printout, like, so-and-so. Yep, I know so-and-so. Okay, give them this. Let me know how it goes. None of that requires me to physically be standing there watching her provide care.
Right.
They love her. She does a great job, and her our level of communication and partnership in a team in that setting is exceptional. So, that kind of gives you a taste of like, okay, this is going to be so much better if we can push that forward into the school districts, if we can push it forward into occupational medicine, and certainly in that setting.
Yeah, I love everything about each one of these contracts. I think that they're a great addition for rural care. I myself, I live very rural. I used to work in a very rural outpatient hospital based practice, and we did very similar things to this 20 years ago, but that was not necessarily out of a need. I don't want to say it was like a financial or sustainability model. It was because our patients didn't have access.
Right.
Yeah.
So this was, 20 some years ago, our patients would come to us and say, can you provide PT for my infant? Because I cannot afford to drive to the next big city an hour away. I don't have transportation. And so we really did try to make ourselves very versatile in what we offered. We did a contract with a local facility to do aquatic physical therapy, closed down a hotel who had a pool. They would block it just for our patients. So we maintained confidentiality and everything. Now, there was all kinds of other, things that came along with that too. We did the school-based contract as well. We had a home health contract. But again, it was out of the necessity that our patients didn't have access to those things. Now, access has improved in 20 years, slightly, not great, but it has improved a little bit. But the fact that you guys are doing this because of several different reasons, I mean, that says a lot about your creativity, your innovation to, drive your practice forward. This is only going to benefit everybody in the long run, right?
We hope so.
Yeah, definitely. So tell me a little bit about mentorship. So mentorship, yeah, I know you guys have already kind of talked and touched base on this a little bit as to how you value your clinicians and how you want to elevate them. But how does mentorship and leadership development evolve for both PTs and PTAs? And if this model is going to work well, like what does that look like?
So he pointed at me because those are sort of my main areas of focus, interest, stuff that I'm really.
It's your bread and butter, huh?
I'm passionate about, that I care about, and that I find to be like rewarding. So as far as mentorship, I would say first off, like, we love hiring new professionals. It is wonderful to have someone with a clean slate. It is wonderful to have someone who is passionate about, they just finished and they're so excited to work. I will also say that our longest standing employees that have been with us 9 and 10 years were new professionals, right? So they started with us as babies and now they're like seasoned professionals and, getting gray hair and having children and doing all these things that we've watched them progress through. So formally, we've always mentored, and that's why these people are still with us, right? Because they felt like they had a relationship where they could grow and sustain and change over the years and still feel like they were being rewarded in the best way possible. We have more recently in the last few years come up with a more formalized mentorship program. So we've heard the need for it. People are asking those questions. You say the students, they are told, like, ask about this. It matters, because it does matter. So we basically use the same program, whether it's a PT or PTA. It's easy for us to do that because we have really strong PTAs. So, we have one of our long-term employees as a PTA. So she can very easily be a mentor. She practices PT, but she also does a lot of stuff for us that's administrative. Like, she understands insurance. She understands, if the phone is ringing and everyone's stressed out, like, she's the first person who can answer the phone and be like, yeah, I got it. And it's hysterical because I'm like, some of the PTs are like, oh, I can't answer the phone. And the PTA is like, I got it. I can answer the phone. I can treat this person. I can answer somebody else's question about insurance authorization. I can do it all. So when we hire someone, we certainly have a structured program where within the first week, they're meeting with us. They're meeting with their mentor the first day one, in reviewing goals, establishing that relationship. We have weekly check-ins for, I think, the first month. I'd have to look at it formally because we're not in hiring. We aren't in a window of hiring right now because we can't find anyone. But we certainly, I think it's the first month they're meeting once a week. Then we cut down to every other week. We do quarterly check-ins with the whole group. So the new hire, the established clinician, and then also Jeremy and I, and kind of review this. These are the things that have come up about in our mentorship meetings. These are the things that we're progressing to. These are the goals that we've established. And we run that whole program for 2 years. So for 2 years, there are initially weekly, then biweekly, then monthly, then quarterly check-ins between the new employee, whether they're a new professional or not, and the established employee, and then us as well. And everyone's path is different. So we hired a PT during COVID who had all COVID clinicals. And she was like excited to work local, great opportunity for us, great opportunity for her. But she was like, I didn't see any outpatients during my outpatient clinical rotation. It was 2020.
Mm-hmm.
So we hired her, and for 8 weeks, she basically had like a student rotation. So for 8 weeks, her mentor and she worked together for 8 weeks. She had no individual schedule at all. And then we started what our normal process would be for when we hire. When we start, the first couple of weeks, you're not seeing anyone, you're working through these sorts of things. We hired a PTA who was transferring a license in. She had not worked professionally, but was licensed in a different state. And there was a lapse in time. And she came and just hung out. She learned, she basically acted like a tech, but it allowed her the window to kind of front load some of those things you may have done in a window where she wasn't able to see any patients yet. And we did that until she was able to actually have her license transfer in and to start interacting with patients. So, we have a framework. Everyone doesn't always fit into it, but we will do whatever is needed in order to get us all to that kind of same starting point. And then from there on, everyone has the same mentorship opportunity. And we do try to specifically pick like personality type or who you think someone might jive with or who they might be more comfortable interacting with, and make that fit a positive one from the start so that people feel like they can go to their mentor every second, not just during a once weekly meeting. That doesn't work. You have to have a person that you can outreach to when you need it and when you need the support.
And
So,
the formal length process is 24 months, but it doesn't end there. I just wanted to add that in.
Yeah, for sure.
It is in perpetuity as long as they're both employees.
Yep.
So you said 24 months?
24 months is the formal length. Yeah.
It was a formal. So for 2 full years, you're going to have somebody in your corner.
Yeah.
Yep.
Mm-hmm. Yeah.
And you can tell who was mentored by who. You know what I mean? You can tell who was someone's mentor. You can tell it in their personal relationships. You can tell it in who they go to first to ask questions. You can tell it in who bought somebody's baby an extra present. You can, you can get all those things because it's a relationship. So
yeah, definitely. I mean, I have to say that I would not be or have had the opportunities that I've had it not been for very specific mentors that were in my path and my journey. And you mentioned that you guys have been to Graham sessions. You mentioned PPS and that you're actively involved in your state and advocacy and all of these things. And I don't preach to the audience about being an association member so I can beat them over the head with it. That's not my goal. My goal is for them to understand the connection between, especially I think for PTAs, there's a lot of benefit there if you seek it out. But by getting yourself closer and in the proximity of the people who have like-minded and they have the same issues as you and they're going through the same things, I think that positions you a lot better to, kind of take things on or to find opportunity or to find that mentorship and that leadership. And that's what kind of drives it forward. So yeah, it's not necessarily that I'm like, oh, you should be an association member because I say you should be one. It's because I have actually felt the benefit. My name has been brought up where it may have not originally been brought up. I've had doors open because of, getting into the close proximity of the people around me. So to me, there is a tangible benefit to being a member. And I love seeing when we talked about advocacy and you said earlier something about, you were like, oh, wow, look, it finally happened. But there's something to be said when you were a part of that change, when you're like, I sent 5 letters on behalf of this and look, it made a difference. Now maybe there was hundreds of other letters that went too, but to know that you took part in that, it feels good to know that your fingertips were on that particular action and that you did something good, right? Like it feels good. I love that you mentioned your PTA, who is a really great administrator too. That's kind of like where the whole PTA plus title came from, was because I kept running into people who would say, well, I'm a PTA, but I'm also, X, Y, and Z, fill in the blank. Like I do this, I do that. I personal train on the side. I'm a marathon runner or whatever, fill in the blank. And so that's kind of where that whole title came from, is because I kept hearing people, PTs and PTA, say, well, yeah, I'm a physical therapist, but also I do all these other things like that go beyond our title, right?
Absolutely.
Yeah.
And it's not, the title is the title and the license is the license, but it's really about the people. And whether you're a PT or a PTA or a tech or a like whatever you are, there are certain personalities that are driven to be a certain way. And really you just have to take that personality and cultivate it and allow it to be the best it can be, no matter what the title is. And obviously you have to work within the restrictions of the title sometimes, but you allow the person to grow. And that's really what we've made our focus point, is allowing the person to grow in the way they want to.
I like that. Cultivate them where they are, right? Instead of trying to change it. Like, no, you got to be this way. Like if personality and characteristics, those are hard to change, but cultivate what they have and drive that forward. So I like that. That's good. Yeah. All right. So the big, ugly conversation that not everybody likes to talk about is the modifier question. So what are PTAs missing when it comes to understanding the language, the contracts behind modifiers, how their work is valued, especially in these outpatient clinics? So, this is something that it's really hard to explain in an educational setting. This is something that you learn on the job when I send students into the clinic so that they can learn from you for 5, 6, 7, 8 weeks. Modifiers, this might be the first time that they've had any chance to see this or touch it. So tell me about that. What are we missing?
So this is another piece where the medical model impacted us, because this is already in place for PAs, right? And so a PA visit might have that modifier reduction. And so, it's really important to understand how it works, which is obviously a 15% reduction on any code that a physical therapist assistant performs more than 10% of, which is almost anything, for those payers that institute the modifier. But number one is really, you want the place that you're working to have an EMR that automatically integrates the modifier, so you don't have to think about it too much. And so, for example, our EMR, if I'm a PTA and I have a schedule, it's automatically implemented on every patient on my schedule. The one place where it gets a little bit tricky is like if PT1 hands off to PTA1 at the end of a session, and I do 1 unit of Therax with that patient at the end, and I'm the PTA, I then have to remember to manually add that modifier onto the end. So that being said, the modifier shouldn't be there, right? It's another imposition from insurance companies that devalues a portion of the healthcare model at a time when we're just trying to allow patients to get proper access, whether it's through a PT or a PTA. And the standard of care that they receive is not going to be less when they see a PTA. And in some cases, it could potentially be more. And so it really is another one of those impositions by the insurance industry that, in my mind, should go away. But do you have anything to add? Or
No, I think you covered it all.
Yeah, we could argue about it all day, whether or not it belongs there or not, right? Yeah, but it is there. And there were a lot of people who really came down pretty hard on APTA whenever this whole change occurred. But, I remember talking to the people who were literally right there in the, room whenever all of this kind of came down about it. And there was not really much APTA could do about it. But it's there and we have to work with it.
Right. Well,
and it's not like it doesn't happen with other health professionals as well.
Right. I mean, the APTA doesn't control the fee schedule any more than I do.
Right.
And so it's imposed on us. And so if we want to reduce the impositions on us, we either have to continue to advocate or get out of that particular model scheme, the insurance model. So we either have to keep applying pressure in doing what we can as a group, or we have to get out of it. And those are the two choices. Otherwise, people are going to continue to shove rules down our throat that we don't like, because in the end, the insurance company is trying to make money and we're trying to survive. And so that's the constant struggle. They're trying to make as much money as possible by restricting access and restricting payment. And we're just trying to be professionals serving a population of people that need our care. So that's the challenge.
It's no different than look at a fee schedule. You know, I can say I'm charging $300 for an evaluation, and the insurance company is going to come back and say, we pay you $50.
Mm-hmm.
We had a PT call us and say, APTA New York's not doing enough to get us paid at an appropriate rate. Mm-hmm. And I said, APTA New York has nothing to do with our fee schedule. Like, you have to advocate on behalf of yourself. You have to get with other practices and advocate on behalf of the region. That's all we can do, because the insurance companies in this model control everything. And that's where the heart of the issue is in our medical model.
Right.
That makes me every time I talk about it.
Gets you fired up, huh? That's okay. There's a lot of things that we could talk about that could get us fired up. It's interesting that you mentioned about the advocacy earlier. This is kind of on a slightly different topic, but Advocacy 101, you mentioned that if other states are doing it, whenever, New York has changed to this general supervision or other states doing it, that's a little bit of Advocacy 101. I'm kind of an infant when it comes to advocacy. I've done Capitol Hill a couple of times, I think twice. I've done my state one time as well. But these are things, this is the language that you learn. So when you go in and you're talking to the aides, or if you're talking to the legislators, they're going to ask you that, like, well, who else is doing this? So that's kind of like a little 101 tip, is that if other states have similar practices or laws and rules, then that kind of gives you a little bit of an edge too, is kind of having that information.
So no matter what you're fighting for, there's always someone who's going to be fighting for the opposite thing. And
So
having proof of concept shows the legislator, who are always afraid of the safety component of changing a law, that there has been no detrimental or negative effect of enhancing access of X, Y, or Z service, right? And so that's like the biggest thing, is proof of concept. Has there been a detrimental effect to kind of go against whoever your opposition is? But then also, one of the biggest things is, how is it going to impact the constituents of the legislator? And so, am I going to get voted back into office if I support this, or is people going to be against me, and how many people does it impact, and that sort of thing? So the constituency is a huge factor in having support for any sort of legislation that you're trying to move forward. And then, of course, you have a champion. Like, you have to have a champion legislator pushes it forward. And obviously, if their status is as high as can be in whatever realm that you're trying to push this legislation forward in, that's very, very helpful.
Well, and I would say, like, it's interesting because this whole conversation started with the APTA conversation. And, like, to me, that's the whole point, is that we have all these players. There's payment people, there's legislation people. We can't be everything to everyone. You can't be a private practice owner and running a business and providing care for patients, and then also having these roles on national committees, and then also be the person that's doing everything legislation wise, or doing everything to get payment back. So, like, that's why I pay dues, right? Because I want someone else to do some of that. I want someone who's as passionate as I am about employee engagement and mentorship, but about lobbying to change legislation, or it's about lobbying to change payment, that they're the people doing it. Like, you're my dollars, so you can do that, because you're going to be way better at it than I am.
Yeah. Share the burden. Yeah. So true. And when you show up to Washington, D.C. to go and advocate, there's 1,000 other groups that are there to advocate on their own issues. If you don't make noise, you're going to be buried. So you can't assume that the person that you're talking to even knows what physical therapy is. You have got to come in prepared, ready to go, and confident in your answers. Okay, quick game. All right. So this is called advocacy, worth it or not. Okay. So we'll start with Megan first. You get the first question. I'm going to give you a topic and you're going to tell me if it's worth it or not, and then tell me why. You ready?
Okay. Mhm.
Okay. Paying professional membership dues.
Yes. I think I just said it. It's worth it.
I
to
know
me
we
because
just talked about that.
I'm
Yeah.
right? So I'm happy to pay someone else to help me in those ways.
Okay. Jeremy, you're next. Writing one email to a legislator.
Worth it. And it's so easy. If you click a button now out of APTA general emails they send to your inbox, or APTA New York or whatever state you're in, you click a button, put in your zip code, it sends it off, and it's done. And then within 3 seconds, I get a reply from the legislator's office. And then generally within a week, I get a more
reply.
Personalized reply from the legislator's office. Definitely worth it.
Yeah, absolutely. Okay, Megan, you're next. Showing up to at least one advocacy day or event per year.
If applicable and if you're able to do it, definitely worth it. So it gives you a viewpoint of what are my dollars going to. Like it backs up all of those other things of like, I'm paying these dues, I'm struggling in this way. You get to see what's happening behind the curtain, and you have a whole new appreciation and understanding for those sorts of things when you're able to immerse yourself in them.
Really quick.
It's so true. Yeah.
Multiple things we've said, but like when we went to the Graham sessions, we sat at a breakfast table and everyone at the table was from a different state, and they were all having the same challenges we were. So just by immersing yourself with people that are like-minded in a similar situation, it makes you feel better because you realize everyone has the same challenges. You're not alone.
It's not just me.
Yeah, exactly.
Okay, Jeremy, I think this one's you, but educating one PTA student on policy.
Oh, worth it, of course. I mean, it's important for them for everyone, whether PT or PTA, to understand why we're doing what we're doing. And the education piece goes miles towards improving their understanding, but also improving their perception of you. And that if you understand something and explain it to them in a way that they then understand, they consider you to some extent a mentor. They trust you in that realm, and it might allow you to enhance your practice by having that person come back and work with you or whatever. So of course, worth it.
Great. Okay, Megan, I'm going to have you close this out with our plus point, and then Jeremy, you can also speak to this as well. But if a PTA in New York asked you, why should I care about legislation or advocacy at all, what would you tell them?
I would tell them that it's going to affect them every single day. So you are a professional, you have a license in New York State, and every single day when you get to go to work and have the privilege of interacting with patients, legislation decides who that is we get to interact with and how we get to interact with them. So having an understanding, knowing even if you don't like something, that there's a way to work through it and figure out what you do and what you don't like and how you can impact change is of value every single day.
And then I would say, how much do you like the dollars you spent on your education, and how much do you appreciate your paycheck? Because all of those things are dictated by advocacy and legislation. Whether it's, there's bills in New York about making PT a primary care copay profession versus a specialist where, the copays are generally higher. So all of those things filter down to how much a PT or PTA can get paid. And by improving access and improving reimbursement and improving policy, it all makes our profession better. And if you plan on graduating from college and spending 10 or 20 or 30 years in the profession, you definitely should be / could be interested in making it better every day.
And you want it to be sustainable.
Right.
We didn't do all of this so that we could start over.
I like how you said improve, because we can't change everything, but we can make improvements and incremental improvements.
For sure.
That moves the needle as well, right?
Yeah.
Absolutely.
Great. Jeremy, Megan, thank you so much for joining. I appreciate all of your wise words and really kind of helping us break this news from New York State on the whole general supervision for PTAs. It's a big deal. It really is, and one that needs to be celebrated. So I appreciate you two giving us your time today. So thank you so much.
Thank you.
Thanks for listening to PTA Plus, the podcast for PTAs by PTAs. Subscribe, follow us on social, and share the show. elevate yourself. This show is for educational purposes only. No clinical decision making should be made from its content. See you next time.